Hi, everyone. Good afternoon, and thank you for joining us today for our webinar titled Equity Center Sterilization Counseling, Evidence, Consent, and Practical Pearls. We hope you are all doing well and staying safe. My name is Nicole Nguyen, Program Manager of the Family Planning Access Care and Treatment Program, or also known as Family PAC, at the California Prevention Training Center. The CAPTC, under contract with the California Department of Healthcare Services Office of Family Planning, is sponsoring today's event. And so before we get started, I'd like to go over some housekeeping slides if this is your first time with us using the GoToWebinar platform. The top right ribbon on your screen is the control panel. The questions icon controls where you can submit questions and comments. The paperclip icon controls where you can access any handouts, and the settings icon controls your audio connection preference. This three-dot icon is how you can switch to full screen mode. And then to check your audio, click on the settings icon. From there, select your desired setting to join either through your computer or by calling in through your phone. If your internet connection is shaky, we highly recommend you call in through your phone for the best possible sound. And then please use the questions icon to submit questions and comments for our presenters throughout the webinar. Today's webinar will take about 90 minutes and include time at the end for Q&A. So please send in your questions. Our speaker will try to address as many of them as possible. The webinar will be recorded, and we will send out a follow-up email with the recording, the slide deck, and evaluation at the end for you to fill out. So please fill that out. Your feedback is extremely important to us and really help us develop our future content. And then I want to acknowledge that we are working with the University of Nevada, Reno School of Medicine to provide CMEs for this event. This webinar qualifies for 1.5 CME credits and only available to those who watched the webinar live today. Those who watched the recording afterward will not be eligible for any CME credits. The link to access your certificate will be included in the follow-up email along with the recording, the slides, and the evaluation survey. And then for transparency, I want to disclose that all of our presenters, planners, or anyone in a position to control the content of this CME activity have indicated that neither they nor their spouse or legally recognized domestic partner has any financial relationships with commercial interests related to the content of this activity. All right, now I get to introduce our awesome presenters. We are thrilled to have three presenters with us today. First is Dr. Eleanor Bimla Schwartz. Dr. Schwartz is a professor of medicine at the University of California, San Francisco, and chief of the Division of General Internal Medicine at San Francisco General Hospital. She previously served as a senior medical expert for the U.S. Department of Veterans Affairs and on the FDA's Advisory Committee on Reproductive Health Drugs, and as medical consultant for California Office of Family Planning from 2014 to 2016. And then our second presenter is Finn Wilder-Piper. Finn is an out loud, visibly queer, non-binary nurse practitioner. They provide comprehensive sexual and reproductive health care, gender-affirming care, and abortion care in Midcoast, Maine, as well as via telehealth. They approach care and education from a background in reproductive and social justice with the goal of increasing access to competent, equitable, and compassionate care for all. Outside of work, Finn enjoys spending time with their family, cooking delicious food, going on outdoors adventures, gardening, tending to farm animals, and having spontaneous dance parties. And then lastly, our third presenter is Lindsay Wilder-Piper. Lindsay is a sexual and reproductive health nurse practitioner. She trains and sees patients in Massachusetts at health quarters, also in New Hampshire at the Joan G. Lovering Health Center, and in Maine at the local FQHC. They provide medication and procedural abortion care, other family planning care, gynecologic care, cancer screening, vasectomies, gender-affirming hormone care, STI testing and treatment, and intrauterine insemination. In addition to being enthusiastic about providing and talking about abortion, Lindsay loves to run and garden, to hike and play, and be with close friends and family. Lindsay parents three lovely young people who are social justice savvy in their own rights, and with her partner, Lindsay runs a small farm. So thank you for joining us today. We are really excited that all three of you are presenting on this very important topic. Lindsay is not here right now because they're in a L&D situation right now with labor delivery, but they will be joining us later. And then with that, I will hand the mic over to Bimla first. Thank you. Okay, so let me stop sharing. And make Bimla. Go ahead, Bimla, you should be able to present.
All right. Thank you all for zooming in. And again, no financial relationships with any organizations that might be influencing my thinking on these topics. I do recognize that gender, sexuality, and family planning are inherently personal and complex topics, and that not all individuals who pursue tubal sterilization identify as women, even if I default to talk about women seeking tubal sterilization. So we're going to be talking today about equity-centered contraceptive counseling, and in particularly sterilization counseling. And I want to frame this conversation with this cartoon, which may be familiar to many of you, but I want to just remind ourselves that what equity-focused counseling means is that we are not providing the exact same counseling to all individuals, but we are first striving to understand what that individual might need to be learning from us, and then trying to provide the information that will be most useful in helping that individual see clearly and make decisions that will best serve their own needs. Our official learning objectives are to recognize historical and ongoing injustices in reproductive health, to apply reproductive justice principles to patient-centered contraceptive counseling and care, to make sure that you're able to effectively compare the safety and effectiveness of tubal sterilization, vasectomy, and long-acting reversible contraceptives when you're talking with patients, to balance this goal of providing patient-centered care with the federal consent requirements, which we do have to observe, and to identify best practices for referrals and options for procedural training if these procedures are not things that you are currently offering to patients. So I want to start with this beautiful piece of artwork, which is from an Australian artist. It was created in honor of Sorry Day, which Australia recognizes and offers a period of reflections on the injustices experienced by Aboriginal people in Australia. And we do have a need in this country for our own Sorry Day to recognize that there have been historical injustices in reproductive health where people have undergone forced and coerced sterilization, and that the echoes of these experiences continue to affect patient care today. Despite how much we would like to say otherwise, our patients still report that they are having biased counseling and that their personal characteristics are shaping that. And the history of truly forced and coerced sterilization is really not that far back. I grew up with a dear friend who was an only child and could clearly articulate from as early as I could remember that the reason she was an only child is because she had darker skin than I did, and her mother had been involuntarily sterilized when my friend was born. Our goal in thinking about how we're counseling our patients is always to be delivering high quality healthcare. We want to be doing the right thing for the right patient at the right time in the right way to achieve the best possible results. And when it comes to contraceptive counseling, that means we want to make sure our patients really truly feel they have access to all methods of birth control that might be relevant to them. And when we think about what access actually means, it's a complicated concept that involves a number of different things. We need to make sure not just that our patients have heard of the method, but ideally that they've also talked to a clinician about the method and understand that that would be a safe method for them given their personal health circumstances. They also need to know whether their clinic actually offers the method, and if not, they need to know where they would go if they wanted that method, and ideally, how hard it would be for them to get there. A lot of us take for granted the fact that we in California have a commitment to making sure that patients can access all methods without any cost or copay, but not all of our patients know that, and questions about affordability really run high on many patients' minds even today. And it's important that we make sure we're telling anybody who's enrolled in the Family Pack program they can have any method of their choice and it will be free, because the best contraceptive for any given person is the one they want to use at this point in their life, understanding that these things can change over time and usually do. We need to approach these conversations with cultural humility We need to avoid assumptions as we try to identify our patients' individual personal goals. We need to invite them to share their personal and their family and friends' experiences with these various methods, understanding that we will have one point of view and one perspective, but that's being laid out with many other pieces of information. And often the personal experience, the peer, family, friends will be those that are most valued. We need to understand that views on fertility vary in different communities, and we need to address internet misinformation, which unfortunately remains prevalent, being mindful of the fact that for many of our patients, reading and thinking about numbers and probabilities are things that they haven't had as much practice with as people who've done a whole bunch of schooling. Person-centered contraceptive counseling involves making sure we're letting our patients know that we are taking their preferences about birth control seriously, that we're striving to give them enough information to make the best decision about birth control for them as a person, that we're respecting them as a person, and letting the patient say what mattered to them about their birth control options. And as we do that, we need to recognize there are a lot of different things that matter to my patients, and I'm sure to your patients, and that can revolve around things related to their skin, acne, bleeding, their menstrual periods, how a birth control method may impact their risk of cancer, whether they can keep the method confidential, how convenient it is. Again, this issue of cost always at the background of many people's lives, whether the method will impact their future fertility, whether it's going to affect their sex drive, whether it's going to affect their mood, whether it's going to cause pain, whether it's safe, whether it's going to cost weight gain. And in many parts of the country, blessedly not in California right now, but this question about whether or not they would potentially end up with a need to seek abortion services, whether that would be available, whether that would be something that would be acceptable to them as a person, which often leads to questions around effectiveness and how well does the method actually work. And then as we're thinking about reproductive justice and our historical injustices, we also need to keep in mind patients' autonomy. And if they want to try a method, will they be able to change their mind if it's not something that they're finding is working for them? Which is a reminder to me to put a star highlighting the option of IUD self-removal. If we leave the threads long enough, it's very easy for patients to remove an IUD. When it's not easy, it's something that we're always happy to help with in clinic. And I would say the thing we really don't want to be doing is turning anybody away who says today is the day they would like their IUD or their implant out. So a question for all of you. With Nicole's help, I think I can get your sense. What form of birth control is currently most used in the United States? We've got some options here, and you can go ahead and vote. Abortion, pills, condoms, tubal surgery, intrauterine device. It's fun to see all the answers coming in. My understanding is we had a couple hundred people log on, so good to see the numbers percolating up here.
Yes, and I'm waiting until at least 80 or 90% has voted, and then I will share the results.
Perfect.
So give everyone a few more seconds.
Our next goal is just to try to make sure we get that many people out and voting in the next national elections.
Yes. Okay, so I think we have right now at 75, so I'm going to close and share the results. So it looks like the highest is pills at 40%, followed by condoms at 33, and then IUD at 18.
And that may reflect many clinicians' experiences where they're spending a lot of time talking about pills and a lot of time talking about condoms. But in fact, tubal surgery is the most commonly used form of birth control in the US. 11.5% of US women under the age of 50 have had a tubal surgery. And that means that of those who are currently using contraception, sorry for the typo there, or I guess we just say it differently, 22% of all contracepting women in the US are relying on a tubal surgery. So this is a really common method of contraception in the US. And it's a method that has been increasing in prevalence since the Dobbs decision, as there are people who are having more reasons to worry they may not be able to access abortion services if that would be needed for them. We are seeing increasing rates both of tubal sterilization and vasectomy among young adults across the country. And one of the challenges that we really want to address with this webinar is the issue that very few women in the US report any counseling about sterilization when asked in the past year. Not everybody gets any birth control counseling at all. Only 17.1% of US women report that they got any birth control counseling in the past year. But when we look at that, even among those who are getting birth control counseling, very few of them are getting any counseling about sterilization, which means there's a lot of possibility that people's understanding of how sterilization compares to their other options may not really be up to date or evidence-based. And so one of my big goals for all of you listening in is to make sure that when you're talking to your patients about sterilization, you have at least some discussion of this as an option, even if it's not the option that they're interested in right now, because what we want to do is try to make sure our patients are well informed about all of their options. Now, we don't often talk about surgical sterilization in Sex Ed 101. We don't think this is a good option for teens, and that most people in this country end up wanting to have a pregnancy at some point in the future. But I would argue, given how many people end up opting for surgical sterilization, we need to be talking about it more than we are, because we have people who may not be fully informed about their options. We also have this habit of using inconsistent and inaccurate terminology. The most commonly used phrase in this country remains having your tubes tied, and that isn't reflective of what's actually being done. Sometimes people are talking about tubal ligation. That is also not usually what is being done. So preferred terms are probably in this day and age female sterilization, tubal sterilization, salpingectomy, permanent contraception, or things that I think highlight the fact that this actually is a surgery, such as a birth control surgery, or talking about surgical contraception. One of the big problems with the idea of having your tubes tied is that it makes it sound like it's really easy to have your tubes untied, and that is not true. And I know in our pre-session survey, it sounded like this audience is very clear on the fact that these surgeries tend to be permanent and not reversible. But Google is not so clear on that. And many of our patients who look on Google end up thinking like, this might be a pretty easily reversible method. In fact, these misperceptions are extremely common. In a number of studies, we've seen that 40% of women believe it's easy to reverse their tubal surgery. The flip of that, only 42% know that tubal surgery is not easily reversible. Only 46% believed it would be hard to get pregnant in the future after having a tubal surgery. And even after reviewing the federal consent form that has been in place for many, many years now and was designed to try to protect people from coercive sterilization, 34% still incorrectly believe that sterilization is reversible. And maybe that's because we're having people try to use these forms who aren't able to read easily. Maybe it's because the font is too small, but we need to be doing a better job of making sure that our patients really understand that if you have a tubal surgery, the chance of pregnancy after that is very, very low. The other thing we need to be working on making sure our patients understand is that IUDs don't adversely affect future fertility. And unfortunately, here we also have misperceptions where people still believe that if they use an IUD, it may make it hard for them to get pregnant in the future. So What proportion of U.S. women who undergo tubal surgery report regrets or a desire for tubal reversal after their permanent contraceptive surgery? You think it's 1 out of 100, 1 out of 20, 5%, 1 out of 10, 10%, or 1 out of 5, 20%?
The poll has been launched, and I'm waiting for everyone to get a chance to vote.
Thank you so much, Nicole. You're doing it all very seamlessly.
Thank you. Okay, so we're almost at, I'll close it at 80. We're at 78.
All right.
Yep, got it. Share the results. So it looks like the most is 1 out of 20 at 5%, followed by 1 out of 100 at 1%, and then third is 1 out of 10%, and then 1 out of 5 is the last one.
And again, I think that reflects a sense of that would be great if only 1 out of 100 people who had a permanent contraceptive surgery ended up with regrets. But what we have seen is that actually the number is 1 of every 5. It's over 20% of US women who end up with a report of a desire for reversal. This is our most recent data from the National Survey of Family Growth. You can see in red here that we've been maybe getting better. If you're a glass half full person, you'd say like, yeah, those numbers are better than they had been. We had numbers that were up in the 26, 27% in the not so distant past, where 1 of every 4 people who are having one of these surgeries were reporting that they had a desire for reversal. But I really think this means we have some ways to go because of those who desire reversal, less than 1% are actually able to achieve that. Fertility treatments are expensive. They're rarely covered by insurance. And so this is not to say that this isn't a good option for some patients. Again, over 80% of people are happy, and that's better than we get with our birth control pills, where about only 50% want to keep using them at 1 year. So it's not to say this is never a good option for patients. It's just to say we want to make sure they're really well counseled, because it's really different to have a desire for reversal or regrets and know that you were well counseled and well educated before you had your procedure than to end up with regrets and say, I wish somebody had have told me. I didn't realize that was the case. So when might tubal sterilization be a good option? For someone who's sure they will never want to be pregnant in the future. And when they're thinking about their options, they may have other questions, even if they're sure they never want to be pregnant. What's the safest form of birth control? What's the most effective form of birth control? So when we're thinking about safety, when we're thinking about procedural complications, again, we want to make sure we're comparing what it's like to actually have a surgery to have another office-based procedure. So if we're looking at risks of infection, when you have a laparoscopic tubal ligation procedure, 3% of those procedures end up with infectious complications, as opposed to 0.3% after placement of an intrauterine contraceptive. So again, about a 10-fold difference there. When we look at bleeding complications, 0.8% of tubal sterilization surgeries end up with those complications, a number that's much lower after intrauterine contraceptive placement. 20 times safer to have an IUD placed. Again, doesn't mean one's the better or the worse option for any particular individual, but that if safety is a concern, then we need to recognize that the intrauterine contraceptive is definitely safer than a tubal surgery. How about pain after the procedure? We've had a lot of coverage in the media about concerns that pain with IUD placement may be dismissed by providers, and that patients are having more pain than they're being credited with. And again, it's not that nobody has pain with IUD placement, but when we looked at claims from Medi-Cal clients in the state of California, we see that pain after IUD placement is much less common than after tubal surgery. And that's not just on the day of the procedure, where we might expect tubal surgery is a much more involved procedure, but 2 days to 3 months after the procedure, we see 11.5% of those who had tubal surgery have some claims, meaning they sought health care for pelvic pain, compared to only 4.5% of those with an IUD placed. 3 to 6 months after the procedure, 6.6% of those who had tubal surgery had claims for seeking health care related to pelvic pain, compared to 3.4% of those who had a hormonal IUD placed. And 6 to 12 months, again, still more common with tubal surgery. So safety and pain, not reasons to try to have a tubal surgery. What about the effectiveness? And when we're talking about real world effectiveness, we want to be thinking about long-acting reversible contraceptives, which are shown here in blue, the IUDs and the implants, and the ways those compare to injections like depo-medroxyprogesterone acetate, shown in orange, and are commonly used pills, patch, ring, shown here in green. And this is data from the St. Louis Choice study, which was a prospective observational cohort study. And we saw in that about 4.8% of patients who got started with a pill, patch, and ring had a contraceptive failure, meaning a pregnancy, in their first year of use. In their second year, that number had upped to 7.8%, and by the third year, that was up to 9.4%. While those using IUD or an implant had low rates below 1%, even out to 3 years. Depo-Provera, you will see, is got rates of failure that are similar to an IUD or an implant if our patients are getting all 4 shots a year. But it's important to note that in this study, only half of the patients actually managed to get to clinic to get all of those 4 shots. So this is not really all patients who are trying to use Depo-Provera. Which is a reminder, though, that if your patient likes the idea of Depo-Provera, we do have the option of allowing them to self-inject their Depo-Provera, and a lot of reason to think patients who are self-injecting are more likely to get all 4 shots over the course of a year than those who have to make arrangements to get to clinic to get their shots. So one of the big takeaways from this session today is the idea that surgical contraception may not be the most effective form of birth control for women. It should not be considered the gold standard. It doesn't mean that it's not the right option for some patients, but we also need to think about other options if effectiveness is what's really important to our patients. Tubal surgery methods have evolved over time. Back in the 1880s, when Dr. Lundgren first performed a tubal sterilization, to the early 2000s, when we had Esher, the hysteroscopic option, approved by the FDA. Esher was removed from the market in 2018 due to market concerns, but for anybody who has those coils still in place, we need to be clear, not because of concerns of safety, not because of concerns of efficacy, seems to have worked as well as the other approaches we have. And then more recently, we've had a shift towards doing more bilateral salpingectomy, in part because of the belief that this will help people decrease their risk of ovarian cancer. But it's important to remember that it's not the only contraceptive method that will decrease your rates of ovarian cancer. Any of the hormonal methods decrease ovarian cancer risk. And if that's what our patient's priority is, then we need to have a conversation about how to prevent ovarian cancer. But that shouldn't be a reason to choose a method in and of itself. So even bilateral salpingectomy has failed. All forms of contraceptive have failed some patients, which means that, and there have been at least 5 intrauterine pregnancies reported after bilateral salpingectomy. So we need to be clear that there is still some chance that you could end up pregnant when you don't want to, regardless of what form of contraception we provide. And it's important, therefore, for us to also be familiar in how to help our patients end pregnancies if they don't want to be pregnant at this point. That can be easily done using mifepristone, which some people refer to as Plan C, can be ordered either through the mail or through a brick and mortar certified pharmacy. It's then followed by misoprostol, 4 pills, as you can see here on the screen, that are either placed under the tongue or in the cheek or in the vagina and left there for about 30 minutes to soak in. If this is not something you are directly providing your patients, you can refer them to plancpills.org to find a telehealth provider who can. But if this is something you want to add to your practice, it's really easy to do so. And I would encourage you to visit this other online training, Abortion Pill CME, hosted at the teachtraining.org group. And just to be clear that any of our family pack clients who become pregnant are presumptively eligible for Medi-Cal, whether they desire prenatal care, labor delivery, 365 days of postpartum care, or they are seeking abortion. All of those services are available to them for free in the state of California. So coming back to this idea that surgical contraception may not be the most effective form of birth control, what is the data that's leading me to say that? So one of those is a study we did of Medi-Cal claims data. And what we saw there was that within 1 year, 2.9% of our Medi-Cal clients had claims related to pregnancy. And by 3 years post-procedure, 8.4% had claims related to pregnancy. So I would say those are numbers that are really far from 100% perfect, and make us think there is still some chance that you could get pregnant even if you go through all the days off work and pain of having a tubal surgery. Is it just that one study that makes us think that? No, there's also data actually from the National Survey of Family Growth. This is actually 4 separate data sets that we analyze them and put them together in this one publication that was published in 2024 in the New England Journal of Medicine Evidence paper. In this paper, we did a survival analysis of time to pregnancy after somebody reported a tubal sterilization. Participants were censored at the time that they tried to have their tubal reversed, or they had any infertility treatment, or they had something else that would have prevented pregnancy, like a hysterectomy or a bilateral oophorectomy. And this is what that data shows. Again, very far from nobody ever gets pregnant. It's not to say that it's not still a highly effective method, but depending on the wave, we saw rates of pregnancy within 1 year that ranged from 1.4 to 2.9%. In the most recent data from the National Survey of Family Growth, and I should be clear, this is not the most recent data because NSFG is always continuing on and there are more recent waves. We just have not been able to analyze those as yet because they are no longer publicly accessible. So from our most recent publicly accessible National Survey of Family Growth data, we can say that 2.9% were pregnant by 12 months after tubal sterilization, and 8.4% reported some sort of pregnancy by 120 months or 5 years after their sterilization. Any pregnancy at all across all of those waves was reported by 2.9 to 5.2% of participants. How does that compare to our Medi-Cal claims data from similar time periods? It's actually pretty aligned. Pregnancy within 12 months in that California Medicaid or Medi-Cal data was 2.6%. In the National Survey of Family Growth, it was 2.9%. So that's a whole lot different than what we're often historically been quoting from the 1996 CREST trial, which was done in academic centers, which reported that less than 1.5% of these sterilization procedures failed within 5 years. And I think it's important for our patients to know it doesn't mean it's not a good option. Doesn't mean it's not a good option for them. It just means that it isn't something that will never fail. Other data on this topic comes from Utah, where we had some colleagues look at 1,752 permanent contraceptive procedures that had been done in their health system. Of those, they identified 693 that had interval placement of the fill sheet clips, and there they found 15 pregnancies, or again, a failure rate that was above 2%, 2.2%. What they published was driven down to look further about those who had their fill sheet clips placed per instruction. And when the fill sheet clips were placed per instruction, the failure rates are lower. But I don't think our patients necessarily know when we're taking to them to have a procedure whether we're going to succeed or not. And I think we have to be honest with them about failure rates for all comers, because not every time these clips are attempted to be used are they placed perfectly. So conclusion of this part of our talk is that tubal sterilization appears less effective than many have anticipated. So how does surgery compare to an IUD? And this is one thing that I would also hope that you guys are taking away from this talk as you think about your approach to counseling, is that you're always clarifying for patients whether they're thinking about having an IUD placed or they're thinking about having a tubal surgery, what this comparison is. And what we saw among our California Medi-Cal clients is that those who had a copper IUD placed were no more likely to end up pregnant, and in fact looked to be a little bit less likely to become pregnant than those who had tubal surgery. You can see the adjusted incident rate ratio here is below 1, 0.92, although that confidence interval does cross 1, meaning it's not a statistically significant difference. And the hormonal IUD, which we know is usually more effective than the copper IUD, was significantly less likely to be followed by pregnancy than people who had tubal surgery with Medi-Cal funding. In fact, our hormonal IUD users were 28% less likely to become pregnant than those who had tubal surgery, which doesn't mean you should never have a tubal surgery. It just means that because you never want to get pregnant and effectiveness is super important to you, be the reason that you're making that choice. This is that data again, looking at the absolute pregnancy rates. And again, we saw more pregnancies following IUD placement than might be expected in the state of California as well. Although again, the IUDs were more effective than the tubal surgery. So when we're comparing contraceptive effectiveness in the first year per 1,000 patients, what do we know about all the data that's been put out there? We know that the contraceptive implant that slides into people's arms looks to be actually our most effective option, with failure rates of 0.2 to 0.5 per 1,000 patients. Vasectomy is likely the next most effective option, with only 1.5 per 1,000 failures. Hormonal IUD looks like it comes out ahead of tubal sterilization surgery, at least in our data from about a decade ago. And then we have the non-hormonal IUD. And then just so we're clear, periodic abstinence, though there are some folks who end up saying that would be their most effective option, does have a pretty high typical use failure rate. So a reminder that Nexplanon is easier to place than an IV. It's a single rod of etonogestrel. It doesn't have estrogen, so it has no risk of causing blood clots for people who have chronic medical conditions. I should have updated this slide because just recently the FDA updated the labeling, so it's now not just labeled for it is now labeled for 5 years, consistent with the data that we've had for a good number of years. 80% are happy and want to continue at 1 year. That's a similar continuation rate to IUDs. Again, better than pills, patch, or ring. Similar happiness to what we see with tubal sterilization. The big difference is that you can get rid of your implant easily if you would like to. Most common reason for discontinuation is spotting. And if you don't like it, we can take it out. So one last question for you. When were you trained to place and remove contraceptive implants? Do we have anybody who was trained in the last year? 1 to 5 years ago, 5 to 10 years ago, more than 10 years ago? Do we have anybody who is providing family planning services who has not yet completed the Nexplanon training?
So the
We're
polls
getting
has
good
been
numbers.
launched.
Thank you so much. So it looks like we've got some people being shy on this one. And we can move on because it looks like we have a good number of people who have not yet completed the Nexplanon training. And I would say if I have one takeaway for you from this presentation, it would be that it is really easy to get trained. And I am trained originally, I'm a board certified general internist. I don't really like procedures. I don't like blood. Nexplanon placement and removal is totally my type of procedure. And you can get trained. You just visit this website and you can get signed up for training today. And again, this is a really important service to be offering your patients because it is more effective than tubal surgery. And if they don't like it, it's easily reversible. And it's very, very safe, even for the patients I take care of, many of whom have chronic medical conditions. Really, the only contraindication to use of an implant is current breast cancer. So lots of information for us to compare and contrast for our patients. I want to share with you a resource that hopefully can make that easier for you to do when you're speaking with your patients. There's a website we developed called Advancing Access, and it's freely available to you if you go to advancingaccess.ucsf.edu. There is a side-by-side chart you can download that puts all of the information together about how tubal surgery compares to the other long-acting methods. But if it's easier for folks to click through the aspects that they're actually interested in, whether that's the safety, whether that's how long they have to wait to have it placed, whether it's how long it takes to recover from the procedure, whether it's pain or how well it works, all of that information is there and available. And I think what I would really like to see as we move forward is that all of our patients have reviewed all of this information that might be useful as they are trying to make their own decisions before anybody goes forward with a surgery that will not allow them the chance to change their mind. And so with that, I'm happy to turn the microphone and slide sharing over to my colleagues on the other side of the country who it's been a pleasure to collaborate with. I think I have stopped sharing and hopefully you are now able to take it away.
All right. Thank you so much. That was excellent. Hi, my name's Finn. I'm a nurse practitioner out in Maine. I'm going to start us off with some information about vasectomy. So, fun little comic here. And people come in right with a lot of questions about vasectomies. You know, is it castration? Does it affect libido? How about erectile function? And so, you know, when we're doing counseling for our patients, it's really important to help them understand what this is and what it isn't. As we're looking at sterilization methods, like Bimla was saying, vasectomy is more effective than tubals. If proper use is done, as in there is a backup method for the first 3 months. Lifetime is about 1 in 2,000 pregnancies with a vasectomy versus somewhere around 1 in 200 with the tubals. So vasectomy, usually a 3-visit service. There's an intake visit and a consult. This is where we get an idea of the patient's goals and perceptions about vasectomy. We do education. We talk about pre and post procedure recommendations. We get medical, social history, trauma. Of course, we always want to be coming from a trauma-informed model. Oftentimes there is a physical exam done here if this is an in-office visit, just to make sure that the vas deferens are easy to find. We go through informed consent, talk about what support is going to look like, and that exam is part of what determines if a patient is appropriate for an outpatient vasectomy. The other thing being that this is done under local, and so we go through that as well. Then they have their procedure visit and then their microscopy follow-up. You know, when we're talking about informed consent, shared decision making, so with shared decision making, we want to hold space for the patient to be connected to the process. We want to offer all of the options. Looking at values and preferences, I think Bimla did an excellent job of kind of going over how we can hold all of that for our patients. And then, you know, doing informed consent, we're maintaining awareness of that history of forced sterilization. We're educating about the procedure, risks, benefits. We answer the questions. We make sure that the patient understands what's going to be happening to their body, and that they're clear and confident in their decision. So getting a history in the consult, going through preconceptions. So, you know, does a vasectomy involve losing your testicles? Does it make you impotent? Does it make it so that you get prostate cancer? Lots of things that there's lots of misunderstandings out there, and we try to really carefully reassure our patients that this is not going to affect their sexual function. There's no cancer risk. There's no cardiovascular risk. That was a myth for a while. You know, overall that this is very safe. You know, we do talk about anytime we're breaking skin, there is a risk of infection. Generally very low. This is considered a minimally invasive procedure with a low risk of infection. Of course, our patients, you know, who have suboptimal glucose management, if they're on immune modulators, if they have prosthetics, you know, those sorts of folks, those may be people you consider a pre-op dose of an antimicrobial for. You know, again, just taking patient history into account, but generally that's not something that's needed. Looking into history of trauma, healthcare trauma, sexual trauma, because of the ways that people access reproductive health services and the needs, people with uteruses and vaginas and vulvas tend to have a lot more exams, have a lot more interaction with healthcare. People with penises and testicles tend to have very little. They're not, you know, they may like turn and cough once for a hernia check, but it's usually pretty uncomfortable for them to have this area of their body examined and touched. So that's something to be really aware of and thinking about, and preparing for patient needs during the procedure. So, you know, going over this is done under local. It is possible to get it done under general anesthesia. However, depending on insurance, depending on cost, depending on availability, that can really change things. But if somebody feels like truly I'm not going to be able to handle doing this under just local with an anxiolytic, then that's a really important thing to know. We go over the procedure in the consult. I think images are huge. We talk about the location. This says incision. Incision, we are moving away from saying incision because most vasectomies now are done without a scalpel, but there is still a skin opening. You know, that like no scalpel, no needle vasectomy label can be misleading to people. They think, oh, well, then you don't have to like make any kind of break in the skin, but that's not true. We do have to, you know, how it's done, why it works. We want people to bring supportive undergarments. Don't take aspirin for 10 days before, because that, increases bleeding risk. They're going to need some time afterwards, a couple of days. I tell them really chill on the couch, compression, ice, no intercourse for 7 to 10 days. And vasectomy is not permanent right away. That is something that we really have to emphasize with our patients. For most providers, we're going to say about 25 ejaculations in 3 months. And then we want to check a semen sample, because sperm survive in those upper parts of the tubes and the prostate for a good long while. And so when we talk about like post vasectomy pregnancies, I don't have the data in front of me, but it's more common that is happening directly after somebody has had a vasectomy, and then there isn't another backup method on board until they've had their semen analysis. And like I said, no link between vasectomy and prostate cancer, cardiovascular disease, no change in sexual function or testosterone levels, just letting them know all that. Patients ask about reversal a lot. Similarly to tubal, they should expect this to be a permanent option. There are a lot of myths that vasectomy is easily reversible. It's not easily reversible. Reversal is costly. Pregnancy rates after reversal are pretty varied. There's about a 6% rate of seeking reversal after getting a vasectomy. So, the regret rates are a lot lower with vasectomy than with tubal. So certain factors that predict reversal success. So older patients have lower success the longer it's been since the vasectomy. And then of course, partner fertility. So when we're looking at an older patient with a longer time since their vasectomy, and then if their partner is then also older, so it's a two-sided process, of course, getting having a successful pregnancy. With regret post vasectomy, one of the biggest reasons that was cited for regret post vasectomy was somebody getting into a new relationship, particularly men getting divorced and then coming into a new relationship and then wanting to parent a biological child with this new partner. Other things that increased regret rates were people who were childless at the time of their vasectomy or under age 30. However, when we're talking about regret rates, all of this is pretty low. So if we talk about childless men, there was quite a large study that was done immediately after their vasectomy. The regret rate was 4.4%. And at the time of the study, the regret rate was 7.4%. So a little higher, but still less than tubals. And in childbearing people in the study, their regret rate after was only 1.2%. And at the time of the study had only increased to 3.5%. And again, about 6% of all people who get vasectomies do seek reversal. So while regret is it's not like it never happens, it is a lot lower than when we're looking at tubals, which is, kind of the other surgical sterilization option. When we're doing a physical exam, again, thinking about being trauma informed, talking about bodily and genital self-awareness. Some providers do the counseling virtually. So this first kind of appointment with the patient is virtual, and then the exam is just done on the day of the procedure. In that case, there just has to be a disclosure that rarely a patient may need to be referred elsewhere for certain physiology. An in-office, minimally invasive procedure just might not be possible. So that's just something to consider. Does the patient get an in-person consult, which means going to an office and having to have, transportation? although then they are kind of reassured for sure that they are a good candidate for the exam. The other benefit is that if they do their consult in person and they're able to sign their forms in person and all of that, then the day of their exam, when they take their Valium before they, have their procedure, they can take that, enough in advance that they don't have to be waiting around at the clinic. Just a note on state and federal insurance. When you're signing the consent for sterilization form, make sure that it is not expired. This has happened at clinics. Sometimes, it's a little expiration date up in the corner. Somebody overlooks it and then the patient signs it and then it's invalid. And then they come in for their procedure. Oh, your consent is invalid. Now you have to wait a whole nother 30 days to get this done. This is for California residents who are family packed and Medi-Cal clients. So again, noting the expiration date on the form, this is what it looks like. Has to be signed at least 30 days before their procedure, can't exceed 180 days, right? So they have to wait at least a month, but if it's been more than 180 days, then they have to have a new consult and sign the form again. So I wanted to go in a little bit. I know this is about counseling, and to me, in order to do effective counseling, you have to know what the procedure looks like. And I think not as many people are familiar with what vasectomies look like. So when we're looking at doing a vasectomy under local, these are kind of the techniques for doing local anesthesia. The no needle option is the MetaJet, as you can see on figure B here. And that is air injected lidocaine. The pros there, you use less lidocaine, you don't have to use a needle. You can tell patients you're not using a needle. It can create a small hematoma at the skin level. But, I think people really like them. There's no data that says there's better outcomes with a MetaJet or with a needle. I think a needle is also a totally fine way to do numbing. That's how I do it. But yeah, we put lidocaine on the skin and also around the vas deferens. Then we isolate the vas deferens. Conventionally, it was done with a scalpel and an incision. Generally now, most vasectomies are minimally invasive. The official no scalpel vasectomy term has to be done exactly in these steps without any variation in the way that it was outlined by the person who coined the no scalpel vasectomy. So minimally invasive is essentially no scalpel, but if there's any variation in the step. So most people call it minimally invasive. And the American Urological Association recommends either minimally invasive or no scalpel. They're really trying to move away from the scalpel incision. This is kind of what it looks like as we're isolating the vas deferens. So you can see there's a very small opening there that's made, grasping the vas deferens and bringing that up out of the scrotum. Then we need to occlude the vas deferens. So there's different ways to do that. Cautery, something called fascial interposition. So you bring spermatic fascia in between the two ends. Usually then you clip that. The AUA guidelines recommend doing some kind of occlusive technique that combines cautery, fascial interposition, and usually clips as well. Basically, what they don't want is for people to just cut out a piece. And I think that's often what, or just clip it. And again, with the myths, people think, oh, you get a vasectomy, you just get a little clip put on that they can just take off. Well, no, that has a super high failure rate. So we don't want to do that. And if we just cut out a small piece, the vas deferens segments can actually grow back together. So that's what some of these occlusion techniques look like. That's what it looks like in real life, doing cautery into the mucosa of the vas deferens. And then this is what fascial interposition looks like. The fascia is pulled up over the end of the vas deferens and then clipped. And so you can see that one end of the vas deferens is clipped away from the other end. Therefore, they can't grow back together. This is what the post-procedural opening looks like. Very small, very minimal. There are providers who do not suture this. I do throw in one small stitch that's dissolvable. I think people feel a little more comfortable when they see a stitch rather than a hole, even though generally without a stitch, it's going to heal just fine. Potential complications. So really important to counsel on all of these, of course, you know, when people are coming in for their consult. Of note, all of these are pretty low risk. I typically tell people that the one that's most common is bruising or hematoma. Hematoma formation occurs in somewhere between 0.1 to 2% of people getting a vasectomy. So pretty low as far as complication rate goes there. Anecdotally, most of those people did not stay on the couch long enough, and they got up and they were up on their feet and running around, and then they ended up with bruising. So again, low complication rate there. Infection rate also super low, about 0.2 to 1%. There was one study that said up to 4%. It's a little tricky because outcomes are different with the different techniques and with different providers, but the larger study that seems to be more commonly quoted is somewhere from 0.2 to 1% risk of infection. Congestive epididymitis, when you say that, people's eyes get big, they're scared. But really, you know, there is going to be some degree of feeling of fullness afterwards. It does resolve. For some people, it's more uncomfortable, especially if they do get like a true epididymitis, like, you know, inflammation happening. But most often this resolves just fine, and it's, you know, they handle it pretty well. A sperm granuloma, and this is something to know if you're, especially if you're doing on an exam, a testicular exam on somebody who has had a vasectomy. This is a small ball of scar tissue on the vas deferens. It is caused by the body's reaction to any sperm leaking out of the area. And really, you know, it's not painful, it's not dangerous, but it does feel like a small ball of tissue there. And so I always counsel patients, you know, you may feel this, as long as it's not on your testicle, it's something to be less worried about. Persistent fertility, we really want people to get their post-vasectomy semen analysis done. You know, we want them to come in at that 3-month mark and bring their sample, and we look at it under the microscope. For my patients that are further away, especially if they do have some form of insurance and they don't want to drive all the way back to the clinic, you know, I live and work in Maine. It's a spread out state. I have some people who drive a few hours. Then we can always order it to a local hospital lab too. But we really recommend getting that done because then they can be confident that their partner, if desired, can discontinue their other contraception, but not before that. Anytime we use lidocaine, of course, risk of reaction there. Post-vasectomy pain, you know, we are, as I tell my patients, mucking about in tissue, and there will be a little bit of soreness, but generally it's very manageable with ice and Tylenol. And need for hospitalization is extremely rare, extremely rare. You know, if somebody has an infection that they ignore, you know, some people get hematomas and they go in to be seen, but the risk of actually being hospitalized for something like that is almost nothing. Again, talking about the post-procedure follow-up, we don't consider a vasectomy failed until we see motile sperm a full 6 months post-op. So usually if somebody comes in at their 12-week spot and there's any motile sperm, we have them come back in another month. If I see a very rare non-motile sperm, you know, 1 or 2 on a slide, I'm not that worried about it, assuming that the sample is not too old. So it really needs to be kept at body temp and less than 2 hours old to have a good PVSA done. And with that, I am going to hand it over to Lindsay to talk about some benefits of getting vasectomy into your practice and some pearls on that.
All right, hi folks. Unfortunately, I'm having some technical difficulties with my camera, so you'll have to see my face at another time. But I'm happy to talk to you about adding vasectomy to your practice. This is something that I've been able to do at a few different practices in a few different New England states. And I went back to speak with administrators as a part of developing this portion of the presentation, just to kind of get pearls from those individuals who were part of making that happen, you know, for their organization. So that's, you know, partly what I'm sharing my personal experience of doing that, and then you know, just following back up with folks who I've done it with. So, you know, as the slide here talks about, that it, you know, it's minimally invasive, it's permanent, it doesn't cost a lot to start it up, and it's not as costly for patients, especially when done outpatient. And that it can be a way, if you're looking to, you know, increase your retention of your professionals, whether they be the prescribers or the people who are assisting the prescribers. So, you know, medical assistants, nurses, et cetera, who can learn new skills or assist in a new procedure, I think are more interested in sticking around with their jobs. So that's kind of a positive to that. So, you know, speaking with providers who've become vasectomy skilled, they like expanding their skills and scope, and just, you know, being able to increase access to patients in that way. And then I think, you know, just noting our political climate, that I have seen an increase in patients of all genders coming in and asking about more permanent or long-term contraception. And so I think, you know, adding this not only is a way to diversify your clinical offerings, but also meeting the moment. And so that's just, you know, a sidebar about that. So on my next slide, it just has a discussion of kind of a stepwise process of how do you add that to your practice. So, and I'll kind of go into each point here. And then, yep, that's great. Thank you. So I think it's really important to, you know, if you have a clinical champion, making sure that that person has the support of admin, of billing, you know, of other decision makers in the practice, because you know, if one clinician is sort of leading the charge, but then let's say that person goes out on leave or leaves the practice or whatever, we want the service to be able to continue on. And so, you know, thinking about how are you going to secure the funding to front load getting this started, buying your equipment, paying for training. And then when I talk about training of the whole team, you know, wanting to make sure that the front desk staff have enough of a good script and confidence and training to be able to, on the fly, answer patient questions, or do appropriate screening of patients, or know when to escalate a patient issue or question to the office nurse or one of the providers. And then similarly, training for the medical assistants or the people who are going to be assisting the clinician doing the procedure. And then, of course, assisting or training the people who are actually performing the procedure. So next slide. So training providers. So I've done this in a couple of different ways. I've in 2 locations been a salaried staff clinician, so had my own patient panel there, and trained people on the job with me, kind of, or like set aside some days and they'd travel to my clinic or I'd travel to their clinic. And then I've also been hired as a contract trainer specifically to travel to that clinic and train the provider there who was learning the skill, helping them develop their clinical documents and their protocols and education materials. And it's really helpful to involve the clinicians who will be doing the learning in the development of their policies and procedures, so that they can kind of take what's standard and then tailor it to their own organization. And it just, I think, gets more buy-in from everybody on the team if they have some ownership over, implementing a new service. And there are a lot of different training documents that can be used to prepare the learner before they do hands-on training. And one idea is to kind of get the learner trained up in observing and then assisting and then being the lead in consults, because once they get great at that, the trainer doesn't need to be a part of that anymore, especially if you're paying a contractor to come on site. And that clinician who is on site will just kind of build up a panel of vasectomy patients, and then the trainer can come down on a designated vasectomy day. And so, then they'll have like 2, 3, 4, 5 patients. And so you can have you can try the model of having a heavy procedure training day, which in my experience has been superior for learners to be able to see them in a chunk of procedures rather than one and then waiting a few weeks and seeing another and then waiting, just, for style of learning. And then typically what I've done is, and it's tricky to put a number on procedural training. And I think that there's a lot of discourse right now especially in sexual and reproductive health and in abortion care, about leaning away from specific numbers, because some people come in with some really good proprioception and spatial skills and spatial awareness, and they're just really great with hand skills. And then there are other providers who don't necessarily have it. It's harder for them to master that. And so those would be the people who probably need more numbers. And so just kind of when you have an adult learner, a clinician learner, it's great to have a collaborative relationship, to discuss, what is your goal for today, and kind of help them come to a reasonable assessment of what their level is as they move through their training. And so also incorporating the clinician learner as a teacher of, like, if you have a student or if you have the MA in the room, they can kind of teach that person what's happening, and that's the way for them to own the knowledge of what they're actively learning. And so you'll kind of see here that I'll lead and kind of slowly have the learner take over different aspects of it. And then I'll do one side, further down the line in their training, I'll do one side and then they'll do the other side. And then I step back as the lead and I become the assist. And then at a certain point, when they've trained their MA up to speed, then I'll just be on site, and then they just have access to me in the building, but they're alone in the room with their designated assistant, and they're doing the procedure. So, we put a ballpark around 20 procedures. And then again, just to reiterate that their independence is determined collaboratively. So next. Okay, so I think that, we touched on this a little bit, making the documents specific to your clinic and your state laws and all of those things. And then Finn already mentioned the making sure that the Medicaid consent form is up to date. And, you know, what does your consent form in your clinic look like? And I guess that also depends on what kind of consult visits you're doing, whether it's a teleconsult or in person or that kind of thing. And then just a reminder about the scripts that you want to offer your colleagues. So who's going to take call for the very, very, very rare, you know, triage call about a vasectomy procedure complication? How do they field that? When do they call the lead clinician, et cetera? You know, just creating your EMR templates for that. And there are some really nice pre-crafted ones. Then you can kind of tweak to your practice specifically. You know, what are the front facing like patient materials going to look like? So that's another thing that you want to, you know, just kind of get excited about. And I guess we can go to the next slide. So this is another thing that you want to think about when you're adding this. Eventually, what will you use for your model? Will you have a specific day of like, all right, every Thursday is vasectomy day or whatever, or will you integrate it throughout your day, interspersed with other types of visits? And I think, you know, if you have a very efficient team or if you have a very high demand or high volume, you could certainly do a heavy procedure day. And if you have enough equipment and your team is quite efficient, you could theoretically get, you know, a dozen or more vasectomies done in an 8-hour day. That's a lot of standing and, you know, just thinking about like body mechanics and that sort of thing. But it also, I would say, is maybe you could change your flow. Like you could do like the heavy procedure day while you're getting the people trained up and then move into an integrated model. It really, you know, really depends on how much money you have to buy equipment, you know, thinking about autoclaving. So if you only have 2, you know, vas forceps, you have to get the first one into the autoclave so that by the time the 3rd patient rolls around, you're not having to do it old school style, which is, I say that as a personal pearl of wisdom. This happened to me last week in my clinic. I was training somebody and I was like, where's that sweet piece of equipment that I love to use? And I was like, oh, darn, we're going to have to do it the old school way, which is not my favorite. But anyway, so that was a learning moment. And I was like, yeah, maybe we can have more than 2 full kits. So anyway, that's something to think about procedure flow wise. And then when you're kind of front loading money to buy equipment. All right, next. So scheduling, you know, for many practices, there are going to be 3 appointments needed. And so helping your schedulers know what are the correct time slots with which provider, who can do them, you know, who's signed off for this type of visit or that type of visit. At one of the clinics where I work, all of the advanced practice clinicians are signed off for doing the vasectomy consults and initial exam. Incidentally, at that clinic, only a physician is doing the vasectomies. And then all of the APCs are doing the 1st and 3rd visit. And the 3rd visit is just the, you know, looking under the microscope and doing this sperm count. At another clinic where I work, it's the, you know, APCs are doing you know, the whole kit and caboodle, but they don't do, and I think it has to do with their CLIA designation. They send their specimens off to a lab that can read them quickly for their patients. So anyway, that's just kind of some, you know, detailed information about clinic specific things. You know, determining who is doing which part of the visit and making sure that they have the right information to be doing the visit. You know, do you train your nurse or your MA to do the initial counseling and going through the consent form, or is that something that the provider does? You know, that sort of thing. Certainly the provider would be doing like a pre-vasectomy exam if that's what your practice has determined to do. And then making sure, just timing wise, that you're signing the consent forms with enough lead time for, you know, Medicaid to pay for it. And then who's getting the room set up, For the clinician, are they doing it themselves? Has the person learned proper sterile technique? All those kind of things. And then it's sometimes really nice to have pictures of what a kit should look like, what a setup should look like, having the to-go bags with the proper dressings and the specimen cup ready to go, or with the bacitracin in it. You know, who's prepping the patient? Will the medical assistant do this for the clinician? Will, you know, are they going to be the ones to tape the penis up out of the way, use the HIPAA to kind of cleanse the surgical field, or is the clinician going to do all of that? You know, so kind of working through all of these things. And some of this stuff is like you learn as you go, but these are important things to be thinking about up front. We can go on to the next one. And this is regarding billing. So the first one, you know, the first visit, and some people will charge for the first visit. Some people will charge just for the second visit, kind of a bundle, and visit 1, 2, and 3 will just be paid for at that time. Some people will charge for the consult a little bit, and then they'll charge it the bulk for the vasectomy itself. And then the follow-up, the microscopy, is free. So it really varies depending on what people are using. But definitely these are the codes that you'll want to use for your initial counseling, and then your procedure code, and then what is your ICD-10 for the vasectomy encounter. And then these are just kind of like a range of what the cost can be. And so, you know, at a health center versus a private office. And then of course I didn't include anything that would include like an OR fee, because that would be, you know, that's just an extraordinary fee. But those are patients that we're sort of risking out of the outpatient setting. And then, yeah, so I guess just kind of noting what is important per state and in your sort of practice area and your population. All right, we can look at the next slide. The other thing to do is to see who is going to be providing the service. Is this something that you expect all of the providers to be able to do? What will that take to train them all up? What kind of pace of training everybody? Can APCs do this in your state? I think that's a good thing to learn up front. And then, you know, figuring out the budget to either bring in a contract trainer or, you know, send people somewhere to get some training done. You know, I think cross-pollinating and working together with other programs is generally always a benefit to us in sexual and reproductive health. And then knowing who your local referrals are going to be as far as, you know, sort of out of range complications, or if you have a odd or interesting finding on an exam that you want a urologist to take a look at, just kind of getting your provider, who's in your corner, who's going to be doing this. All right, and then other considerations, next slide. You know, knowing what your requirements are, and these are sort of Pearl specific from managers or administrators or executive directors that I spoke with. You know, so what is your fixed fee that if you work in FQHC, are there creative ways to subsidize the fees for people who are uninsured or underinsured? And then, you know, what is your reimbursement allowance? You know, just kind of taking all of those into account before you try to launch. It would be premature to launch if you haven't taken these things into consideration. And then on the next slide, this is another way to drum up, like, you need to have the patients to provide the service. How are you going to do this? Do you have somebody in your practice who's quite talented at this? You know, I've worked at different locations, as I've said, and there have been different levels of skill as far as like getting the word out. A funny word of mouth anecdote is that at one clinic, we did the entire fire department in that city because they all just like chatted to each other. But then once they're done, you know, and so we need to like find a new set of patients. But that was funny. One of the executive directors said that was a fantastic word of mouth. Next slide. So these are just kind of reiterating, you know, words of wisdom, and some of them are direct quotes. So, you know, making sure the Medicaid forms are completed correctly so that you get paid. The scheduling appropriately, it can't be understated because it can really throw off a clinic flow if people aren't on the same page. the cost of the training actually is pretty low, and adding the adding to your med mal doesn't, it's not a very heavy lift as far as like adding this procedure. And then the answer was like, well, it may not make us big money, but it's the right thing to do, and we're a lot less expensive than like private offices. This is speaking from the nonprofit. So next, this is kind of a continuation of words of wisdom. If you have Title 10, there's nothing that should be holding you back. Dive right in. It's an asset to have this service. And, checking your liability coverage. Like I said, it's not that expensive. Making sure that you have your CLIA designation set up, or what your plan is for post-vas analysis. And then, patients ask a lot about the technique, which Finn kind of went into pretty well. So I think that's really important to make sure your staff can answer those questions. And then making sure you identify your key learners internally. So we can go to the next one. And I think that was my quick overview of how to start this service in your practice. So thanks.
All right. Wow, that was awesome. Thank you, Lindsay, for doing that. I know with the tech trouble, but that was awesome. And thank you, Finn, for advancing those slides. So now we can get started on our Q&A. So we have a couple Q&A in. And what I'll do is I'll just switch off. So I'll ask one question toward Dr. Schwartz, and then I'll ask one for Finn on vasectomy. So the first one is, do we know what the regret is about? Is it the inability to have more children? Is it because of complications or pain, or body dysmorphia?
I think all of those things have happened. The known world is full of lots of reasons why people end up with regrets, with the question being, do we know at a national level? The National Survey of Family Growth doesn't collect that type of additional detail. So I think we're left with just the anecdotes that each of us probably have collected from our own clinical practice. But I would say there's nothing sadder for me than having a patient say they want me to help them get pregnant after they've had a tubal sterilization procedure, and have to explain to them that, unfortunately, with our publicly funded healthcare system, as trim as it is, the options are very limited.
And then this would be for Finn, but I think Bimba can answer this too. Are there any states allowing for virtual 30-day consent form signatures consistent with telehealth? Could this be done as a digital signature through the telehealth consult?
Yeah, so I didn't have a ton of experience with this because I only do my consults in person. However, I took a quick peek, and it can be. The consents can be signed virtually as long as it has a date and time stamp on it, which most like virtual signing, like DocuSign and that sort of thing, have a date and time stamp.
All right, so next, what data exists on the efficacy of salpingectomy, specifically given the increasing practice of opportunistic or preventative salpingectomy?
This is a really important question for us, and I think there are people who have theorized that salpingectomy would be more effective than some of the older approaches, but as yet we don't have any population level data. I would love to see some. Unfortunately, our data sets like the National Survey of Family Growth do not differentiate between what type of sterilization procedure a patient underwent. So with the National Survey of Family Growth data, we can't tell ESHRE from tubal sterilization from salpingectomy. With the claims data, it is also difficult to distinguish between tubal sterilization and salpingectomy. One could do it using electronic health record review, natural language processing type approaches, and we are trying to make that happen, but it's actually harder than one might think, and we don't have any of that data ready to share as yet.
And then before I jump to the next question, I just want to remind when our presenters will be staying on for an extra 15 minutes to 1:45 to answer these questions. So if you have to leave right away, still put your questions in and we'll get it answered, and you can watch it in the recording, but you will still get your full 1.5 CNME credits if you have to leave right at 1:30. So, all right, so next one is for Finn. How would you talk to teens? and counsel them on vasectomy?
Yeah. So when I do talks for teens, and I frequently do talks for like high school classes and stuff like that, I always include vasectomy as an option that's available, with the caveat that most insurances, like private insurances, won't cover till 18, state insurance till age 21, and that it is permanent. And it's something that they may consider in the future. Unlikely something that they'd be looking into right away. I like to put it in there because then it's kind of in their head. They know about it. And then they've already heard it from me that it's a permanent sterilization option. And so that kind of combats some of the misinformation that's out there on the internet.
So for this one, obviously patient-centered care is of primary consideration and individualized discussions should take place. But what are your thoughts on patients who are undergoing cesarean section and have been cleared that they desire permanent sterilization, and especially those who would have significant risk of morbidity or mortality from a subsequent pregnancy?
And I want to be really clear, if a patient has been well counseled and thinks that such a surgery is the right option for her, then they've got my full support, and I think that's a great option. What I do take a little bit of issue with is our many patients who have chronic medical conditions who think that birth control isn't safe for me, and that the only thing that might be safe for me would be to have a surgery. And with that, I actually have a lot of concern, because clearly surgery is not our safest option, and it's important for people to know that we have a lot of options that don't contain estrogen. If you have a risk of clotting, whether that's because you have diabetes complications or high blood pressure or heart disease, it doesn't mean that your only option is to undergo a surgical sterilization procedure. And yet we do see that people with diabetes are much more likely to have surgeries than people without diabetes. People with high blood pressure are much more likely to have these surgeries than other patients. Our only patients who are actually more likely to have vasectomy than any other patients are our patients with breast cancer. And somehow the breast cancer oncology community seems to be doing a really good job making sure those patients know that they have a lot of options and that those options include vasectomy. But again, it would be really great for all of our patients to have been really thoughtful about all of those options. Again, recognizing not all of our patients have only one partner, and one partner who's willing to have a vasectomy, which is what's needed for a female patient to be able to rely on that vasectomy. But in the circumstance where that is the situation, it's great to give that full consideration. I think the other really important takeaway for all of us is, where is my vasectomy provider? And that's not always super easy to figure out. And I love the call to do some of that training. And in California, that is an MD or required background to start that training. Hopefully, maybe we can get that changed. And in California, we can have more advanced practice clinicians clearly capably doing these procedures. But short of that, sometimes it's a little hard to know where in your community that vasectomy referral would go to. And so I would say that would be another request of all of you. Do that homework, know where that is, so that you can actually be meaningfully counseling your patients on, like, this is an option. If this is what you wanted to do, this is where you would have to go. And again, being clear, in California, these are all free options. There is no out-of-pocket cost. I think some of the differences we see in terms of postpartum sterilization have to do with women having healthcare coverage for a limited time period while they're pregnant and postpartum, and not necessarily knowing that their male partner also has coverage in the state of California, and their male partner could get a vasectomy just the way they have this pregnancy-related contraceptive access.
Yes. So for Finn, I heard that it feels different when I ejaculate. Is this true?
Yeah, so sperm is such a small percentage of ejaculate. There's really no appreciable difference in the volume of ejaculate. So I think that's the first thing to, just reassure people about. They may not realize that really the amount of ejaculate is not changing. They don't maybe realize how small of a percentage sperm actually is of the whole ejaculate. There's no change in erectile or ejaculatory function. We can never know what each individual person's experience is, right? you know, the research typically says there's no change in how it feels, in how it works. That being said, in the first couple of months, there's going to be a little residual soreness. So if this is like at somebody's follow-up visit or like right away, there typically is like, oh, maybe that felt a little sore, or you know, that was a little off. But usually that's just because somebody has just had a procedure. And like I talked about with that sort of like feeling of fullness and maybe a little bit of swelling in the testicular and the epididymal area, until the body kind of figures out kind of consistently reabsorbing the sperm. So I think early on it can feel a little different, but what the data says is that there's no appreciable difference post vasectomy for the majority of people.
So for Bimla, is there an age requirement for sterilization? From the slide title comparing contraceptive effectiveness, what made abstinence have the highest rate out of 1,000 patients?
And so Finn nicely took us through some of the age requirements depend on who is paying, and for those getting government-funded healthcare, you have to be at least 21 years of age to have a tubal sterilization or a vasectomy. That being said, we do also know that rates of regret are higher among younger people, likely because they have more opportunities to have life transitions with new partners where their desires may change. So officially 21 is what I would say with that. In terms of why does abstinence have such a high failure rate in the real world? That is because so often people's intentions to remain abstinence are not things that end up being the reality when their behaviors are taken into account. And a lot of people who are planning on staying abstinent don't manage to. And these are things that we actually do have good data about people who this is what they thought they were doing and this is where they are at 1 year. So I think really important for people who have been sexually active to know that it's fairly addictive behavior. It's hard for people to stay away from.
So what kind of objections did you get from community urologists or your organization malpractice carrier for you to begin performing vasectomies, or insurance companies?
Yeah, very little overall. So community, at least in our area, and I imagine it's probably not so different in many places, urologists have a long wait list and they see a lot of different patients for a lot of different things. And in fact, one of the urologists that I refer to locally for other issues is like, yeah, you can have all my vasectomies. I hate doing them. Take them away. So I think they actually don't mind a little help with the patient load. Maybe there's some urologists, you know, certainly when we talk about the you know, I'm an APC, I'm an NP, and so we talk about kind of like some of the funky relationships between physicians and advanced practice clinicians. They, you know, oh, you can't possibly have the same training or the same outcomes. We do have the, you know, as good, if, you know, if not in some cases, better outcomes. So there's no change in outcome there in vasectomies, regardless of who's doing it, as long as you're well trained. As far as malpractice, really easy to add on, you know, especially if you're already doing any kind of minimally invasive procedures on your malpractice insurance. Not too big of an issue there. So I think overall, you know, not major objections. I don't know, maybe there's a urologist in your town that's really aggressive about their vasectomy turf, and that's entirely possible. But I think we need to be increasing access for patients. And part of that increasing access is making sure that they can find the services, right? And so if it's like, I would like a vasectomy, now I'm going to go on an 8-month urology wait list, and oh, okay, 2 months later, their partner is in seeing me for their medication abortion, right? So instead, let's get these people in and get them seen. And Bill, I really liked what you mentioned about oncologists counseling about vasectomy with their cancer patients, because I think one thing that we don't do is bring up vasectomy when we're talking with our assigned female at birth patients. In all of my exam rooms, I have a big sign that says, you know, like, now offering vasectomy. It's not a new service, but it still says that. Or have you considered a vasectomy? Because more often than not, male patients end up considering it because their female partners bring it to them as a possibility. Especially when female partners bring it to them and say, you know, I really am trying to get off of XYZ birth control, whether it really isn't feeling like it's working for them, or there's those myths that Bimla was talking about how it's not safe, et cetera, et cetera. But, you know, when female partners bring it to them and suggest it, and then they get talking about it. So bringing it up to your female patients, you know, as one of their options, if they are in, right, a mutually monogamous partnered situation where that makes sense.
And then for Bimla, what stat do you quote to patients about effectiveness of tubal, taking into account the studies that you showed?
So I generally find that my patients have a really hard time thinking about statistics and proportions the way that many folks who have more advanced statistical training do. And I think it can be really helpful to use pictures, such as one that is on the website. I put the link into the chat there, that lets you see that really it's a highly effective method. People are unlikely to get pregnant. But then the question really, I think for many of my patients, is not a specific number, but more how does it compare to the other options? And I think when we're talking about how does it compare to the other options, then I also have to be clear, from what I know, this is not the most effective method. If the most important thing to you is the most effective method, then that is not a reason to have a tubal surgery.
And I'm going to combine these two. This is for Lindsay. One is, how can I come train with you in Maine? And would you be willing to share your protocols?
You may have had to jump off to go deliver a baby. But I'll just jump in real quick. A good way to get connected with training is through an organization called Repro TLC that connects learners with training sites based on their kind of like repro health needs that they're looking to get trained in. So that's one way. Another way is to find a local urologist that is willing to take on students. I know that's how Lindsay trained. She got connected with one of the local urologists and she trained with him. So lots of different ways, and she can certainly provide more information about training ideas. And I missed the second part. It was training, and then
would you be willing to share your protocols?
Oh, yes. Yeah, we can certainly share. I think, you know, protocols, there's you know, techniques that are used, and whether that's a specific clinic protocol or not, it's more provider specific, which technique a provider uses. But we can certainly share things like what we counsel patients on, you know, our informed consent paperwork. Happy to share that. You know, the determining patient eligibility as far as like via physical exam, that's not really a protocol thing. That's more, can you find the vas deferens easily? That's more of a physical exam thing. But yeah, I'm happy to, between the two of us, rustle up some paperwork that we can share.
Wonderful. I think this is our last question too, for Bimla. How can one check on the efficacy of tubal ligation in the long run?
Not sure I fully understand the question. I guess there's two levels. One is at the individual patient level, and at the patient level, we don't currently recommend any follow-up testing. When we were doing Essure procedures, we were having everybody have their tubes evaluated after the procedure, but that is not standardly done for people who are having other approaches to tubal surgery. Again, when people are having vasectomy, that follow-up sperm count does remain very important before people feel that they can rely on it. When we're trying to end up with population level data, that requires that we start with a very clear understanding of everybody who's had the procedure and then follow up on what happens with them. And that's hard to do in the US because we don't have access to healthcare for all. We can do some things like looking at Medi-Cal claims data because Medi-Cal does provide comprehensive care for at least one section of people in California. And hopefully there'll be perhaps some data coming out from our international colleagues who do provide healthcare for all and follow their data in data sets a little more consistently than we are able to do for all comers here in the US. But I think it's really important to take a look at that claims data and think about it alongside what we see in survey data, because we know that in survey data, there is a tendency for people to underreport abortion because there is stigma around abortion still in this country. So we know that when we survey people and say, hey, did you end up having an abortion after you were trying to use this contraceptive, what we see are lower failure rates than what we would see in a system like Medi-Cal that does cover abortion services. So we will be seeing, you know, arguably all of those procedures without that underreporting that might be otherwise seen in survey data.
Okay, and then with that, that concludes our webinar. I want to say thank you so much to Finn, Dr. Schwartz, and Lindsay for presenting. That was awesome. And then you will get an email at the end that will include all the information, the slides, the recording, the link to the CME certificate, and then the protocols and any additional handouts that you want to share with us. I also want to point out we have 4 materials in the handout. If you click on the paperclip up top, we have the new client education materials that we just updated and developed on sterilization and vasectomy in both English and Spanish. So you can share that with your clinic and your clients. And then with that, I want to thank our presenters for this wonderful presentation. Thank you so much. And with that, I hope everyone is staying safe and have the great rest of your day. Thank you so much.
Thank you.